Success in a consultant-level trauma scenario relies on leadership and the vocalized execution of established algorithms. A 25-year-old male arrives in the emergency department trauma room as the victim of a road traffic accident. Before making patient contact, establish control of the environment. Introduce yourself as the trauma leader and confirm that the team is ready and the room is prepared. This monitor displays the patient's initial presentation. Vital signs are critical. Blood pressure 86/45, heart rate 124, oxygen saturation 78% on room air. During the primary survey, you identify decreased air entry on the left side of the chest. The combination of profound hypoxia, hypotension, and unilateral absent breath sounds leads to a clear diagnosis: a tension pneumothorax. In the opening minutes of a trauma activation, prioritizing immediate physiological threats is the only path towards stabilization. This diagnosis requires a two-step intervention: immediate needle decompression, followed by the placement of a definitive chest tube. This diagram maps the required landmarks for the chest tube: the left 4th to 5th intercostal space, positioned between the anterior and mid-axillary lines. Following the procedure, the monitor shows immediate improvement. Blood pressure rises to 110/74. Oxygen saturation reaches 95%. Now that the primary airway and breathing threats are managed, order a chest X-ray, a pelvic X-ray, and a Foley catheter. Proceed to the secondary survey. This involves gathering an ample history and performing a meticulous head-to-toe physical and neurovascular examination. For a patient who remains stable, the next step in the algorithm is scheduling a pan-CT scan under the trauma protocol. While stabilization allows the survey to continue, in trauma management, the situation can change in an instant. The secondary survey is complete, and a 1-liter normal saline bolus has been administered. The patient is being transported to the CT scanner. During transport, the patient suddenly becomes agitated and confused. Blood pressure plummets to 79/36. The heart rate spikes to 116. Proceeding with the CT scan during this collapse is a fundamental error in judgment. As this clinical rubric demonstrates, you must immediately stop transport and repeat the primary survey. Upon reevaluation, the new onset of agitation suggests hypoxia or hypoperfusion, necessitating immediate intubation. At the same time, address the circulatory crisis. Initiate an uncross-matched blood transfusion and trigger the massive transfusion protocol. Surgeons must demonstrate algorithmic rigidity, abandoning linear diagnostic plans the moment a patient's physiology deteriorates. A repeat FAST exam identifies the source of the crash: moderate fluid in the perisplenic, subhepatic, and pelvic regions. The patient remains unstable, despite the administration of fluid and blood. Cancel the CT scan. The patient must move immediately to the OR for an exploratory laparotomy. This OR layout highlights the preparations. Call for surgical assistance and ensure the availability of a cell saver, blood warmer, rapid infuser, and specialized trauma sets. Position the patient supine, with arms extended. The prep area must span from the neck to the mid-thigh. Begin the procedure with a generous midline laparotomy incision. Damage control surgery prioritizes the cessation of hemorrhage over anatomical perfection, halting the lethal triad of hypothermia, acidosis, and coagulopathy. Upon entering the abdomen, the first priority is immediate 4-quadrant packing. Once the packing is complete, pause the procedure. This provides anesthesia with the necessary time to catch up on fluid and blood resuscitation. Once temporarily stabilized, remove the pack systematically, beginning with the least suspected area of injury. You find a grade 3 splenic injury, a 7-centimeter lower pole laceration with active oozing. In a crashing patient with a grade 3 splenic injury, perform a splenectomy. Next, address the grade 2 liver injury, a 5-centimeter right lobe laceration. Options for hepatic hemorrhage control include sandwich packing, the Pringle maneuver, omentectomy, balloon tamponade, and hemostatic agents. Utilizing a wide arsenal of hemostatic techniques is essential for managing a hostile abdomen. After performing the splenectomy and controlling the liver bleeding, the abdomen is closed and the patient is transferred to the ICU. The first priority in the postoperative phase is initiating the tertiary survey. This survey is a systematic search for injuries that may have been missed during the initial resuscitation and damage control phases. This checklist shows the final required steps. Once hemodynamically stable, the patient must complete the initially delayed pan-CT scan. Moving the patient out of the OR is only the first objective. Rigorous postoperative vigilance is required to ensure survival. On postoperative day 1, the patient becomes tachycardic at 118, and the mean arterial pressure drops to 68. Laboratory results show a significant drop in hemoglobin, falling from 11 down to 8. This graph illustrates the clinical crisis. The dropping hemoglobin and MAP indicate active, delayed rebleeding from the liver. The choice is between re-exploration and interventional radiology. The patient is already packed and remains only marginally stable. The definitive management in this scenario is a CT angiogram, followed by potential embolization by interventional radiology. This animation shows the embolization process, which provides targeted hemorrhage control without the physiological stress of reopening the abdomen. High-level trauma care is a continuous loop of reassessment, prioritizing physiological stability over anatomical perfection through the strategic use of all hospital resources.